University of York. This is the Research Room.
Hello, and welcome back to the Research Room with me, Lucy Ather.
And me, Janine Healy.
And today in the Research Room, we're joined by two of the team members from the BART trial. We have Dr. Rebekah Carney and Professor Sophie Parker with us. So thank you very much for joining us in the Research Room. We're very excited to learn all about your project.
Thank you so much. Thank you for having us.
Yeah, very
You're
welcome. So yeah, just to start us off, could you introduce yourselves for us? Rebekah, should we start with you?
Yeah, of course. Yeah, so I'm Rebekah. I'm a research fellow at JUICE, which is the Youth Mental Health Research Unit based in Greater Manchester Mental Health Trust. And I'm also one of the trial managers on the BART trial. My predominant area of interest in relation to research is usually around physical health inequalities, but also I've got quite an invested interest in at-risk, so detecting at-risk populations for people with serious mental illness and different clinical disorders.
Great. Oh, well, thank you for coming on.
Thank you.
And Sophie.
Hello. So I'm a consultant clinical psychologist and a professor of youth mental health. And my role on BART is I'm the chief investigator. So apparently ultimately responsible for everything apart from the boss. Everything I've put on the delegation log. So yeah, and my particular area of interest is all around working early with preventative healthcare for young people who are showing high risk signs for difficulties, particularly because at that age group, there's an opportunity to just nudge people back on the right path and reach their potential, essentially, rather than allowing people to become really unwell and then really stuck in a life that really isn't the one they should be living.
Yeah.
So
So you're really interested in kind of getting in there early.
Yes.
Yeah.
Absolutely. Yeah.
Fab. And so you're here to talk to us about BART.
Yes.
That's right. So could you tell us the sort of full title of the trial?
Yes, so BART stands for the Bipolar At-Risk Trial, and the current one that we're running is BART 2. We ran a feasibility study a few years ago, and off the back of the positive results from that study, we're now running BART 2. So that was BART 1, now we're BART 2.
Fab.
Yeah.
BART the second.
Yes.
So we have this little competition where we sort of rate your name.
We do. We're comparing all the short names of all the trials.
Yeah, and so yours, what's your long title again?
The Bipolar At-Risk Trial.
Oh, right, so it's...
I thought you'd like BART.
Yeah, Bipolar At-Risk Trial, so it's got all the letters of the words. That's very good.
Yeah.
But what does it mean, BART? I mean, I think of, say, BART. Does it has a meaning?
It doesn't have a meaning, no. From the young people that we work with, they particularly talk about just say it as it is. So it has a simplicity about it.
Oh, right.
I have an idea in my mind that it might be a bit like Bart Simpson.
I was going to say Bart Simpson.
So a bit of a naughty adolescent, which I would have ticked that box. And a lot of the young people we meet are full of character and full of life. And so it has also that other meaning for me personally.
Well, funny enough, as soon as you said Bart, that was the first thing that went in my head. Bart Simpson.
And that fits very well.
Yeah,
and it's got all the letters. Oh, this is ticking a lot of boxes.
It is, isn't it? So what shall I give it?
Yeah, you have to rate it out of 10.
I'm going to give it a 9.
Oh, wow. High praise.
Yeah. I'm going to give it an 8. So that's very
nice.
good, an 8 and a 9.
Take an 8, take a 9.
Yeah,
that's high, isn't it?
Very high. Very high GCSE grades.
I think very high. I think a 9 is the highest we've never given out a 10 , so...
Wow. No, we'll never give a 10 out, will we?
You never know.
Well, you never know.
We might do. We might be blown away by an acronym at some point.
Cool. So in a nutshell, can you describe your project? You know, what's it about?
So it's about young people who are presenting with some difficulties, distressing symptoms of different mood states that maybe they don't like. So typically high and low mood, and they're help seeking for those sorts of difficulties. And the trial is all about recruiting that sort of group. There's no current service for that sort of young person. They might be in other services, but not having specialised treatment for these sorts of difficulties, other sorts of treatments which we hypothesise may not be what they need. So the trial is all about testing that. So essentially we're recruiting a group of people in 5 different places in England to test out a new psychological intervention to see if that helps that group of young people who are presenting with those sorts of difficulties. So that's it in a nutshell, really.
So it's a new kind of talking therapy, is it?
Yeah, it's CBT based, so it's not new from that perspective, but it has specific targets of specific types of things, specific types of thinking and processes that we're targeting that we think are particularly particular risk factors for that group.
So when you say young people, what age specifically is that?
So specifically for this trial, we're recruiting people between the ages of 16 to 25.
Okay.
It's the highest sort of peak of age that we see the sort of incidence of something like bipolar disorder and with other at-risk mental state research, psychosis, those sorts of difficulties. It's when most of those sorts of difficulties will sort of emerge and present. It won't capture everyone. So that's not to suggest that it couldn't be younger. It could be, and definitely there's important work to be done for those that are sort of more around the 13, 14, 15 age range, and also older, particularly for women. Might have an older first episode onset than men as their counterparts. But as a specific sort of target, that's what we took, the 16 to 25-year-old age range.
So what's the difference between normal CBT and CBT
bar. So it should look to a young person fairly similar to what they might have already had from CBT. So the difference between this and what you might have for, let's say, if a young person's presenting with just depressed mood, the cognitions, the sorts of thoughts that you might be having, whilst they just might look slightly different and slightly nuanced, and the behaviours in particular might look a bit different. So people might be encouraged in a sort of unipolar or depression type treatment to have behavioural activation, which is go out and about and do lots more in the world. But actually, we find a lot of people who take part in the BART trial, they're already doing too much to combat and counter the possibility of becoming depressed because they're so frightened of that. And they're doing too much. And actually, we have a group of young people who need to learn to rest and need to learn to have less productive time in their schedule. They need a bit more relaxation time and pleasure time and just a more balanced life. But it's because they're really frightened that depression might set in again and get in the way of my goals in life.
Oh, so it's the fear of having depression.
Yeah, fear of depression, fear of high mood. That might also come with a family risk. They may have a family member who's had an episode of bipolar disorder. So they might have some lived experience that they've seen in the family. Might be all sorts of things that are driving that. But they have a real drive and a real need to succeed. And they've sort of become sort of stuck maybe in fears that they have about that.
Yeah. So it sounds like it's CBT, but really focused for people with bipolar or at risk of showing those kind of behaviours. Targeted.
Yes.
Yeah, it's more targeted.
It's very targeted, yeah. And that's what we're testing because it's an EME trial, so it's all about looking at specific mechanisms. Are there specific mechanisms that if we target them in therapy, does that have an outcome that we want to measure later?
Great. Sounds great. I'm on board.
Yeah.
Okay. And so can you tell us a bit about why you're doing the project and the sort of background to what kind of gave you the idea for the research?
So the background to the BART trial is that we've worked for 20 years plus in developing services for people who are at risk of developing psychosis. As a result of that research, you can now, every young person in England can expect to be on a care pathway with nice concordant care. So what you should be getting, and it's as an evidence-based treatment for people with those sorts of difficulties, that isn't the same for a young person who's presenting with these difficulties who might actually be at risk of bipolar disorder. So it's to extend what we know from that research evidence and to try and provide better treatments. And it's both based on research, lived experience, and coming across young people who don't actually fit criteria for lots of other services or treatments.
And I think that's what we find with a lot of people that have got lived experience that we do work with alongside us on the trials, is that they tend to report that they didn't necessarily fit into a particular box. And I know it's not nice to speak about people and humans and stuff like that in a way of you've got to fit in a box, but in relation to care pathways and access and getting access to treatments within particular services, you do need to meet certain criteria. And I think a lot of the people that we do work with, they report that they haven't fit into a box. So they might have gone to one service and gone, I really need help, and actively been trying to access different treatments, and the service has gone, well, you don't meet our criteria, so we'll just pass you over to this one. It's like, oh, well, you're not at risk for developing psychosis because you're not hearing voices and you're not experiencing any kinds of like delusion, so you don't fit within our service, so we'll just refer you on to this service. And people tend to like bash about from one to the other, and then refer back to a GP, and a GP is like, I've exhausted my options, I've sent you to this place, this place, no one's accepting. And it's because that pathway isn't there and that treatment option isn't there, because the evidence base hasn't been built up yet to show, right, there is a real need. And like Sophie was saying before about what is it about these particular treatments that does actually help people. So it's really important to get that evidence base to be able to help the people that don't fit in those, nice, neat boxes.
Yeah, so it's trying to kind of catch those people who don't fit in. There isn't a pathway for them.
Yeah.
And,
yes.
We think maybe there should be, and that's
absolutely
what we're trying to create. And these are people who are at risk of developing bipolar disorder.
That's right, yes.
Yeah. Could you tell us a little bit more about bipolar disorder? I mean, I don't really know much about bipolar.
I don't know a lot about it either. So
there's lots of different types of bipolar disorder, but that's not necessarily something we particularly spend too much time thinking about. But essentially, it'll be a criteria that people meet for that sort of diagnostic label or term that might be used. So people who have had a certain level of experience of mania, so high mood that comes along with lots of different symptoms or difficulties.
Mania, when you say
yes.
Is that what is mania then?
So mania will be someone who's experienced at least 7 straight days with no relief of very, very high mood, very high levels of productivity, and a number of other difficulties. They might include loss of sleep. They might include disinhibited behaviour, so going out and doing things that are uncharacteristic for them. That could be impulsive behaviour, it could be sexual, it could be risky. So there's certain standards, certain criteria that you would have to meet. So that's with the high mood. But then also you've got low mood in the mix as well. So people with long periods of depression and depressed mood for at least 2 weeks, with a number of different difficulties that might come with that. So poor functioning, inability to go to work and do their normal lives, not getting out of bed, not dressing, washing, etc. with that we might see with depressed mood.
So bipolar means two opposites, doesn't it? So is it saying that you have to have the depression and the mania as well?
Not for every type of bipolar. So bipolar 1 is just for people with high mood mania, so that's 7 day plus of that experience. Bipolar 2 is both depressed mood and high mood.
See?
Yeah.
Didn't realise
so it's different types of bipolar.
It's not really named very well, is it?
No, it's not named very well. And it comes from, long histories, doesn't it? These sort of diagnostic terms. And also they become meaningful in our society about different things like labels of schizophrenia or these other labels that are very scary and big and mean certain things to certain people.
Yeah, no, that's really interesting. I've never really learned much about what bipolar actually means, and I didn't realise there were lots of different types. I think, as you were saying, I only really thought it was the one.
Yes, I'm here.
The two extremes, really. But,
yes.
Yeah, but it's a lot more complicated than that, I suppose.
Yes, it is. Yeah.
And am I right in thinking that it's quite widespread bipolar? I think I read that in the UK, 1.3 million people have it. Is that right?
That's right. And actually, that will be a gross underestimate. We know that it's a really difficult diagnosis for people to be accurately sort of diagnosed with or given. There have been some really interesting studies where if you actually assess a huge widespread group of people, a lot of people are missed with bipolar. So that estimate is true, but it's probably an underestimate of what we see. And it's very common for people to go, the average, it's currently reported as 6 to 10 years of people having those sorts of difficulties, what we call a duration of untreated illness. So essentially struggling along without getting that diagnostic label. It takes a long time. And that means you're living your life without any access to evidence-based care or treatments, any help or support. Lots of watch and wait, which is exactly the opposite of what we're trying to do in preventative healthcare, is saying, let's not wait. You know, a 16-year-old, a 17-year-old in the middle of an A-level or in the middle of a BTEC or doing a course, it's so important to keep them in touch with that sort of life. So it's sort of, I hate that watch and wait idea.
It is a bit.
Yeah, it doesn't sound like the best plan, does it?
So do you develop bipolar or are you born with it? Do you know what I mean?
It really depends on which theory you sort of read or adhere to. So all of those theories you could back up with evidence.
Oh, right.
But there is lots to say that actually the genetic predisposition that people maybe lean on or is not as big as we expect.
Really?
So there's lots of people who will develop bipolar disorder over time that don't have any genetic predisposition in terms of having any family members with that difficulty. And we know that there are lots of other sort of difficulties that might give someone a predisposition or causative in that sense. So very high levels of trauma in this sorts of population growing up. Very high levels also, what we're seeing much more recently, big groups of people with neurodiverse sorts of issues. And then, of course, you get missed because you can only have ADHD, right? You can't have anything else.
Right, yeah.
So you might have people with those sorts of difficulties, but also might have mood swings and these sorts of difficulties as well, because it's probably increases your chances rather than decreases your chances. So people get pigeonholed with a label that they were given.
And the label's not helping then, is it?
Not necessarily, not with all of the sorts of other things they might want help in or need help in.
Yeah, because what you find is it tends to get called like diagnostic overshadowing, and I'm just pulling on like a physical health background. Like you see it quite a lot of where people will be dismissed, and it'll be like, oh, that's just because they've got bipolar disorder, or that's just because they've got psychosis. You know, they can't possibly have pains in a certain area. It's just because they're anxious or whatever.
Right. Yeah.
And certain physical health conditions get missed, and then it's like akin to. But, you know, if people are experiencing, let's say, mental health symptoms, then it might get missed because it's like, oh, that person's, just got ADHD, or that person's just got this, that and the other. And it's called like diagnostic overshadowing, where the label, kind of takes the crown.
Yeah, it gets in the way of it.
Gets missed. Yeah. And I think you can attribute that to lots of different conditions. So it may be that people who do have bipolar disorder, but also have a diagnosis of another condition, it might get missed, and they're on waiting lists for treatments and stuff like that. But yeah, it gets attributed to something else.
Yeah.
Oh gosh, that's interesting. Yeah. Never thought of that.
Yeah, sounds like a great idea. We want to stop the watch and wait and just
absolutely
go and
yes,
and we want to
intervene,
as early as possible, or kind of in this age group.
Yes, there's a very high risk of suicide in this particular diagnostic sort of category, so much higher than other sorts of mental health difficulties that we see, and also a lot of disability caused by difficulty with education or work or relationships, essentially. So people living with these sorts of difficulties but actually quite disabled by the sorts of difficulties that they're having, and not receiving help and not receiving diagnosis and not receiving care. So that's sort of all comes into a big mix.
Could be really difficult to live with, and obviously we want to help those people.
Absolutely, yeah. And if there's an opportunity, so through this research, learning about whether or not we can prevent these sorts of difficulties, and obviously, like with any research study, the outcome might be that no, this treatment isn't isn't where it's at. But we might discover new things about, well, what should we do? I definitely believe that this group needs something, and they need things that are a little bit different maybe to what we see in other routine care and services. They need a lot of flexibility. They really, really like our research staff being very flexible, very encouraging, very interpersonally kind of understanding their sort of interpersonal experience, kindness, those sorts of things are all really important to this group. So we measure some of that actually on the trial. So how much they feel, even a blinded researcher, so that's a researcher that can't know what allocation you've had in terms of whether or not you're getting the treatment. We measure that as well. So whether or not you think your researcher is even genuinely interested in your problem, not just collecting data, because that seems to be from our previous qualitative work, really important to this group.
Yeah. Right. Oh, right. Well, it sounds
we'll
very,
see.
very worthwhile.
It does.
This research project.
Yeah, it does. So how does your project work?
Go on, trial manager.
Your time to shine.
This is your moment.
Yes.
Yeah, so I think we've kind of touched on it already, but yeah, it is a randomised control trial, which means that 50% of people will be randomly, pull the names out of the imaginary hat, be allocated to a treatment arm, which is the treatment that we've already been discussing, which is the CBT for bipolar at risk. Or they'll be allocated to treatment as usual. And throughout that journey, every single participant will receive exactly the same outside of that treatment window. So they will be, engaged in baseline assessments, which might take 1 or 2 appointments where they'll complete a whole range of clinical assessments around their symptoms, the difficulties that they're facing, with the researcher, as Sophie's already said, which is who doesn't actually know what treatment arm that participant's been allocated to. And then they will go on to then meet with the researcher again over a course of 12 months. So that'll be at 4 months, 6 months, and that's immediately after whether they've received treatment or whether they've received just treatment as usual. And then again at 12 months. So they're with people within the whole 12 months, they're either seeing a researcher or they're seeing a researcher and a trial therapist. There's also an additional qualitative study, which is an independent researcher who's got lived experience of mental health conditions. So she is totally separate from the research assistants that are conducting the assessments throughout the trial. And she will meet with someone who will take part in an interview about their experiences, what kinds of things they might have found helpful, what kinds of things they might not have found helpful, stuff around how we actually implement that treatment, if it's proven to be effective or not, into clinical practice. So what kinds of things that they would like to see, what things work for them, so that we can just go on to help more people. The treatment itself, I think Sophie's already mentioned. So I'm not the expert in relation to psychological therapy, but So
that's the treatment's delivered by specialist people.
That's right. Yes.
And if people so you say usual care or the CBT bar.
Yeah.
What's the usual care then? Is that sort of...
So it would just be, in relation to whatever services, if they are in receipt of any other services, then, we wouldn't hold back any other treatments. We wouldn't deny them any other treatments. They can go off and, take part in whatever it is that they want to take part in relation to, seeing the GP and things like that. So yes, but they just wouldn't receive anything as part of the trial. So they wouldn't receive any psychological therapy as part of the trial, or any additional visits with a research assistant, for example. That's all really constrained to just the follow-up assessments and time points.
So the follow-ups, we're sort of talking about clinical assessments and questionnaires.
Yes.
There's always questionnaires.
Yes.
So what kind of things are you measuring then? What kind of assessments would they be?
So we're looking at things like appraisal of mood swings, which I know Sophie again has already mentioned. So we're looking at that throughout the trial. We're looking at a whole host of other psychological symptoms. We're looking at things around sleep, aren't we? So we're looking at lots of different self-report questionnaires in relation to just different ways that people would present in terms of clinical present. I don't know if I've said that right.
That sounds good. Yeah.
Is there a main one, or is it just there's a group of them?
You're
always a primary.
That's it.
So the main one that we will live or die by is measures of high and low mood, which we do through an assessment called the SCID. So essentially it's an assessment where we look at the past month and how your mood has been, both in terms of high mood and low mood. And it's a combined score of both of those difficulties at 6 months.
Yeah, we used the SCID.
I have used the SCID
before.
Oh, I can't remember what it stands for, though.
No, I can't either.
The Structured Clinical Instrument for Diagnostic Assessment.
There we go. Yeah. totally forgot what that stood
again.
for. But
Yes.
yeah, and that's like a sort of interview with
It
the
is, yes.
participant, isn't it? And
That's
then they get
right.
a score at the end of that.
Yes. And it's really interesting because lots of referrers that we talk to when we're talking about what the process might be if they want to send someone that they know into the clinical trial, oh, they're scared. It's so long. It's so this. And as a researcher, it's hard.
Yeah, it can
be. Is this a 3? Is this a 2?
Yeah.
Is this anything? It's complex.
Yeah.
But most of the young people we meet actually feel very much the opposite. It
Oh,
really
really?
does their difficulties
I really like
justice.
Oh.
They get asked about things that they've never been asked about, particularly high mood. So people are really, really good experts in depressed mood, low mood, but not very good experts in high mood, in tradition, in regular service. So actually, young people say, I really like this. I think of it a bit like, it would probably show my age, like a Cosmo quiz. What's my score?
Yeah.
They might say to you, what sort of person am I? And I think there's lots of that sort of stuff currently on TikTok Reels and what have
definitely.
you. So young people, it's not actually their experience. So it's really interesting how referrers kind of bias their decision-making based on their own view or opinion about whether or not that would be a good thing to do. But actually most of the young people we see, they really enjoy quite lengthy assessments, being able to really talk about their experiences.
Yeah, I always think it is nicer to have an interview or kind of a conversation. I guess you might not call it an interview.
Yeah.
But you definitely get a lot more detail than just asking someone to tick a box on a questionnaire.
Yes, you do, don't you? When we did those questionnaires, people do go into a lot, of detail. They actually did enjoy it.
You can get a really good understanding of actually what their answer is.
Yes.
Yeah.
Yeah, and I think that goes again to the treatment arm. So I know some people might say, it seems really unfair that I'd sign up to this trial and then there's only 50% chance that I'm going to get the intervention. But what we have found, and particularly working in research for so many years, is that even when people are allocated to that treatment as usual, they still find it beneficial. And even for this population in particular, they really report, it's the first time someone sat and listened to me. I sat and spoke for 2 hours, and it was, I found that really helpful, actually, that, they just actually paid an interest and listened. And I think that does go back to the whole interview over, ticking a box on a form. And we do find as well that some people, if we send out self-report forms to people to complete on the questionnaires, they'll write a whole host of other stuff along the side, like, I've ticked 3, but I really meant 2, and I couldn't decide between these 2 because on Wednesday I felt like this, and then on Thursday I felt like this. And it does give people that outlet, particularly in relation to people that may feel like they've not been listened to, or they've gone to a service and they've gone, you're not quite severe enough for us, but the researchers sat and turned up at each time, no matter what, and listen to what that person's got to say. And they do find that even beneficial in itself of being involved in a trial. And
I think we've both worked on mental health trials, and I find maybe mental health trials in particular, just the process of being involved in the research can be quite beneficial, or people kind of report at least that they enjoy it. And I think people get involved in research as well to help other people.
Yes.
So even if you're not in the treatment arm, people often just enjoy being able to help get a result at the end of it.
Yeah, you're right though. They're different to the questionnaires with just filling them in themselves.
Definitely.
You get a lot more out of it.
So you mentioned that the researchers are blinded, which I'm not sure we've actually spoken about blinding before, but it's quite common on trials. Could you tell us a bit about what that means?
Yeah, of course. Yeah, I mean, it's a bit contentious because some people say, we're not supposed to be saying blinded trial anymore. Right. We should be saying mask trial. And
I didn't know that. Wow.
I think
why is it politically correct or something?
I think it's a language. It's one of these language things that's ever evolving, isn't it? It sometimes it's still reported in trials as blinded trials, or single control blinds and stuff like that, but also referred to as masking as well. And essentially it just means that the researchers that are conducting the assessment, well, in the case of BART anyway, the researchers that are conducting the assessments don't know what treatment, what arm the participants have been allocated to, so they don't know whether they've been receiving treatment or not. And it's particularly important in relation to scoring the assessments. So there's a potential for, if someone knows that someone's received a treatment, they might score them a little bit more favourably, even if they're consciously trying, their subconscious, they're unconscious bias towards going, oh yeah, I can see them, they're doing really well. They may be doing really well, and we would hope that people are doing really well regardless of what allocation they've received. But yeah, it just biases that. So by ensuring that the researchers don't know what that person's received over that time frame, just helps us alleviate some, a proportion of that bias.
Yeah.
And the way that we would do it typically is the researchers would be sat separate from trial therapists, so that there's no crossing over of, you would hope that no one would be able to see anybody else's computer screens, but everyone works in these big shared offices now since COVID. So when researchers answer the phone or they phone up any participant that's taken part in the trial, they reel off a bit of a spiel, which I'm sure they all say in the sleep to themselves, just before you even say hello, I'm not allowed to know what you've received over the last 26 weeks. And similarly, when they're contacting people like the GPs and things like that, just to try and minimise the potential that someone's going to find out what treatment arm they're in. Inevitably, it happens, I think, on pretty much every trial.
Yeah, so again, you can never have it perfect.
Yeah, and it's really difficult to blind the participants, isn't it? They know whether
with the talk and therapy, I think it's pretty much impossible.
You can't do that.
Absolutely. I think it's a bit different with medical trials and
so you might have a placebo.
Yeah, of course.
But you can't really have a placebo.
You can't have a placebo person.
Brilliant. And so, how many participants are you recruiting, or have you finished recruitment?
We have just finished recruitment.
Done.
So hot off the press, we have recruited 337 young people. We're one short of what we were aiming for, 338, but 337 is amazing. Across the 5 different sites, that's what we have recruited to for young people.
Great. And that's across England? Or
that's right, just England. 5 sites in
And
England.
when you say sites, you mean what are the sites? Are they hospitals?
They're mostly NHS sort of community sort of places, but they might. Each site is run by a different hospital, so it's run very differently. But we won't see anyone in hospital per se. That's sort of where we're physically located, but we see people out and about in the community. But yes, we've got Manchester, Sheffield, Norfolk and Suffolk, Birmingham, and Lancashire, so sort of based in Lancaster, just north of where we are in Manchester.
Brilliant.
So you've definitely finished now, that's it? You're not going to still try and get that one person?
We've definitely finished. It's quite complicated to even go beyond each of the months that you have to, so the bureaucracy really is heavy duty
to
just to get that one.
Just for one more.
Yeah, exactly.
Yeah.
So,
and you'll be able to do the analysis still with one, so
yes.
You can let that one go.
We can. We need to just keep people.
So now I guess you'll be doing all the questionnaires, collecting all that data in, and then you can do your analysis, and then you'll get some results, and then maybe you can come back and tell us about the results.
Yes. Oh yes, that'd be good.
Yeah, we'd love to. And particularly I think the qualitative results, that would be really nice to talk about on the podcasts.
Yeah, the qualitative work's really interesting. I think most trials now have a qualitative aspect, but it's really nice. We've spoken to a lot of people about their different qualitative work. It's nice to have those interviews and get that different type of data, really.
Yeah.
You call it rich data, don't you?
I think it is. It's very rich
really
data.
Rich. Yeah. Compared to a P value.
Yeah.
One little number.
We're not going to mention statistics. We can do.
That was in the contract.
And so are those qualitative interviews ongoing at the moment as well?
They're ongoing at the moment. So we've been doing some with participants. So we've recruited about 20 young people to those interviews. Got another handful to go. And the other group that we're interviewing are other important stakeholders. So therapists, referrers, commissioners. So people who make the decisions about whether or not they're going to implement this sort of
That's important,
treatment.
isn't it? Because
if really important.
You can do all this research and then say that we think this is really good, but if they're not involved or they are on board with it, I think is the right word, isn't it?
Yeah, and if you don't hear about what their experiences are that might block a new treatment pathway or what's happening, that's really important to know.
So what's next for your project? So where do you think you're going to go now?
I think one of the important things that we're doing as part of the project that will be really particularly important in this healthcare outcome that we're going to look at is we're doing a lot of work with young people from ethnic minority communities. So we've been running a SWOT, study within a trial.
Oh, we like those.
Yeah, we do.
Trying to recruit more young people from UK ethnic minority backgrounds so that we have a more generalisable sample. And we're trying to understand better their experiences of their healthcare journey so that if we were able to implement this, how we ensure that every young person has fair access to something that might be useful to them. So if I give you a good example, what we know already in these sorts of preventative sort of mental health care pathways is that we're massively underrepresented in terms of serving the communities, the diverse communities that we have in the UK. Whereas actually when you go to an inpatient environment, so exactly the sorts of things that you're trying to prevent happening in the future, the relationship is completely inverse. So you're overrepresented from UK ethnic minorities in those sorts of treatments, and they're usually far more traumatic, enforced, so they're not voluntary usually. You might be sectioned, put in those sorts of spaces. You might be very far away from your family. And so we know that we're not reaching all young people that we should be reaching, and they're often sort of marginalised in terms of not accessing treatment. So we're trying to spend the next year trying to really understand that. So we have a specific bespoke patient and public involvement group, which is just young people from ethnic minority communities who are informing that element of the research. So they've been designing the SWOT, and one of the recruitment animations that we did, they designed with a graphic designer to try and get more people into the trial. And now we're trying to understand, well, how do we better ensure that we can implement this in routine care when we know that group of young people aren't in routine care, so aren't going to be offered these sorts of opportunities. So that's the next piece of thing that we want to do, making sure that it's fairly accessible to all young people that might want to take part.
Very good.
Yeah, that sounds great. That sounds like a really important bit of work.
Yes.
How long will that be?
So that should be wrapping up in the next year. So there's another 12 months of work alongside. So we have an inclusivity work stream, but inclusivity just from the perspective of ethnicity, running alongside the next 12 months of follow-up. So that'll be another year.
Yeah.
And I'm sure it will produce other ideas, other questions that really need to be tested outside of that. So it will provide something, but I'm sure as all research does, more questions.
Curious about those sort of questions.
Yeah, definitely.
It's not a finite thing, isn't it?
No, never.
Answer the question. That's it. Done. Oh,
we'll never run out of research
questions.
Yes.
Brilliant. Yeah. Well, I think the next thing is to grab the hat.
Oh, yes. The next thing is more questions. So we have a bit of fun now. We're going to have some random research questions that we're going to pull out of this lovely hat. Are you going to go first?
Okay.
Drum roll.
If your research had a theme song, what would it be?
I don't know what it would be, but it would have to be catchy and fast-paced is what our young people would say. They get very bored very easily. Move on, boring, come on, move on.
Okay.
Yeah, but I don't know what would.
Techno something.
Fast. Oh, techno.
Yes, some rave music.
Rave
hardcore
music.
rave
That's
music.
it, yeah. So, I don't know one.
Perfect. I know. Well, sadly, I'm not in that age bracket anymore, so I wouldn't know what...
Oh no, you're way out of that one.
Thanks.
Just out.
I'm just outside 16 to 25.
Well, I'm well out of it, aren't I?
No, I like it. Rave. Some upbeat rave music.
Okay. Would you rather have to present your research findings entirely in rhyme or using only interpretive dance?
Oh, definitely interpretive dance.
Would you? Really?
Yeah. It's a running joke, actually. I do in workshops. So when I get people to present back when they're doing little groups, I go, and feel free to use interpretive dance. And it's usually so that the spoken word is less distressing than that. So don't be anxious. So yeah, interpretive dance to take a dose of my own medicine.
Yeah.
Wow. And Rebekah,
I cannot keep still.
Yeah.
I should probably away.
You
This
do
is
well
probably the lot. My Fitbit's screaming at me to stand up right now. It's like, come on, get up and give me 10. So yeah, interpretive dance all the way.
Oh, well, I'll look forward to seeing that when you publish your results and present them at a conference.
We'll come back.
I'll remind you.
Yeah, it's not currently on the dissemination plan,
No.
but maybe it should
Get it on there.
I think it should be. Yeah.
Yeah.
What's your favourite part of your research?
I think for me, it's definitely hearing people's experiences of taking part and how that's affected them in their journey, wherever they may be. So yeah, definitely. There's always value in, the p-values that we've been talking about in terms of proving that things actually do work and have an evidence base. But for me, it is definitely the hearing people's stories and the people that have taken part, and then working with those people throughout to continue to keep making an impact to young people, and knowing that something has actually made a difference to that one person. One person in a sea of hundreds and thousands, it makes a massive difference.
Yeah, definitely. Yeah.
I'd say the same. So listening to young people and listening to their families is really important to me. That's what drives me in terms of doing any of the research we do, any of the rejected grant applications we do. Any of these things is a person sat in front of you and their family, who are usually screaming out for help and going, "Why is no one helping me?" So that's what I love the most.
Yeah, that must be really nice, really rewarding, really.
Very rewarding, yeah.
And I think it just adds a bit of meaning to it as well, because particularly for me being a trial manager, it's everything, people become dehumanized, if you will. So you just get them follow-ups, making sure
it starts to become a bit about the numbers and the target. Yeah.
Exactly. So bringing it back home as to why we're doing this work, and not getting caught up in the dreaded bureaucracy and red tape of you can do this and you can't do that, and saying no, you cannot go past your amount of sessions and you cannot do this, that's not in the protocol. And I think it just really, really adds that meaning to why we do what we do.
Yeah, definitely.
If your research had a mascot, what would it be?
Ooh.
Oh,
do you have a logo or a mascot or anything?
We've got a logo that was developed by someone with lived experience and a graphic designer. And it's a blue and green sort of circle, and it's got a slanted sort of split in it, sort of trying to be an illusion of swinging, differences, complexities with mood. So that's what the logo is, and that's what it means. But essentially, maybe our mascot would be Bart Simpson.
Oh, yeah.
Because he has some of the core qualities of an adolescent that I love.
Yes. Yeah, I think Bart Simpson would be a good one.
I think that's good. You can adopt Bart Simpson for your trial.
Yeah, definitely.
That's a good one. Okay, I'll do one more. What's the next big goal for your project?
I think just finishing. I
already achieved quite a big goal of reaching your recruitment.
Yeah, absolutely. So the recruitment's one of the main first big hurdles anyway. And achieving that, I guess it's just seeing the rest of the project through. So making sure that we keep as many people retained within the trial as possible. And completing the follow-up assessments, completing the qualitative sub-studies, working with the inclusivity work stream and seeing where that kind of takes us, really.
I think as well doing better dissemination. So it's sometimes tricky. So feeding back the results and the outcomes, particularly to young people, that's really hard to do because there's a lot more complexity about holding on to people's numbers and people changing numbers and how you even the contacting of people, keeping people up to date and it being of a way that's engaging and relevant, and it's that sort of thing that sometimes I think we struggle to do.
Yeah, because you typically think, well, I'll obviously publish the results in a paper, but your young people probably aren't reading the papers.
Not necessarily going to do that.
Go to conferences and things.
Perhaps you have to come back on the podcast.
Yes.
Wow. Yeah.
Absolutely. Yeah. So we did, for the last trial for Baby BART, we ran an event in a theatre called the Royal Exchange Theatre in Manchester, so that it was a central location. It wasn't stigmatising. It's not a healthcare setting. It's more creative and fun, so it should be more engaging. And that went well, but you've just got a tiny proportion of the participants that either do or can turn up and take part in that. So it's really hard. You really want to do better than that and do more than that. So yeah. And to say thank you, because they've been part of something. It's the world's first study of its kind. So you really want them to know that and feel that kind of special quality. You might sometimes get that reward at a conference or a thing you do, and you want to say that to every young person that spends the time to take part through usually kind of a desire to get help, but also an altruistic motivation of wanting to give back. So, I'd like us to spend some time thinking about how we could do that really well.
That'd be nice, wouldn't it? Yeah.
Something a bit more personal, I think.
It's hard to think of.
It is.
Yeah.
Good way, really. I think
a party.
A party.
That'd be good.
A rave.
A rave.
Maybe you can have a rave
with the music
and a bit of interpretive dance, and then we all know what we mean.
We've sorted it.
Can
I
come? I want to come to the interpretive dance rave.
Yes.
Oh, well, thank you so much for coming into the research room, telling us all about BART and answering all of our questions. That was
Thank
really,
you
really
so much for having us.
Yeah. Thank you.
You're very welcome.
It's been really good.
Yeah, and we hope you'll come again when we've got some results.
Absolutely.
That'd be great.
Love that.
And for everyone listening, we'll put some information about the trial down in the show notes, with a link to your website and things like that. So if people want to know more, they can just have a look down there.
Yes, always happy to chat to people. Please email.
Yeah, thank you very much.
Thank you.
Bye.
Thank you.
Thank you.